I'm very honored to introduce our first keynote speaker, Dr. Cristina Arevando. She is the medical director at El Rio for behavioral health and medication-assisted treatment. Dr. Arevando is an experienced psychiatrist with a demonstrated history of working in psychiatric inpatient facilities, FQHCs, psychiatric emergency rooms, and with tribal communities. She is skilled in nonprofit organizations, addiction medicine, epidemiology, and clinical research. She is a strong healthcare professional with a Doctor of Medicine from the University of Washington School of Medicine, and she completed her residency in community psychiatry at Yale University. Very honored to introduce her as our first keynote speaker, Dr. Arevando.
Right. Well, good morning, and thank you so much for that wonderful introduction. It is very heartening to see so many people come together to talk about a population that desperately needs our help. I hope that you leave today with a gain in knowledge and in resources, and to go forth and support adolescent behavioral health in Arizona, but that you also feel empowered by seeing so many people who are also present, doing the same work that you are dedicated to. So today, I'm just going to, oh goodness, sorry, did I do that first? I will tell you guys I'm terrible with clickers, so just wave at me if it doesn't look right. Okay, so today, just very quickly, I'm just going to give you a quick overview. I'm going to talk about why we're here. What is it that we're concerned about? We're going to look at a model of looking at the issue of the problem, the person, the community, to make it a way to look at the whole person and not necessarily a diagnostic criteria, because that's really important. And then we're going to talk about what are some of the barriers to care. And then really quickly, some best practices that have been working, have seen some empirical data, and then talk about sort of as an individual, what you can do. So there you go. As Vanessa mentioned, the Surgeon General issued an advisory on youth mental health crisis being further exposed by COVID-19 pandemic, which was released in December 2021. And it's an excellent read if you get a chance to download it and read it. And it's going to be the basis of why we're here today. So now, would it surprise you or anybody to hear that 50 years ago, only 50 years ago, depression in adolescents was considered rare? It wasn't seen. That in 2009, as little as 12, 13 years ago, when they measured high school students in the US, nearly half endorsed feeling stressed by school. But the numbers that endorsed feeling depressed and hopeless was low. By 2019, 1 in 3 high school students reported persistent feelings of depression and hopelessness. 1 in 3. That's a 40% increase from 2019. Now, if you look at the date, you know that's not the pandemic that caused that. So even before the pandemic started, we were seeing an increase in mental health issues in the US for this population. The pandemic did not help an already worsening trend. So even recognizing that mental health wellness is not a continuum. We are seeing increasing levels of distress in all levels of that continuum. So between 2007 and 2018, suicide rates among youth 10 to 14 in the US increased by 57%. So early estimates from the National Center of Health Statistics suggest that there are tragically more than 6,006 deaths by suicide among the age group of 10 to 24 in 2020. We don't, I haven't seen the newest data, but I'm sure that it's not going to be anything that we're happy about. But looking at these national numbers is not sufficient, because when you dive deeper into the data, we see that the distress is not affecting our children equally. During the pandemic, those with prior mental health concerns, those who were in urban communities or rural communities with limited access to technology, children of frontline workers, children with higher baseline ACE scores, those with trauma histories, children that were living in immigrant households, LGBTQ plus children, and children with racial ethnic minority communities, and DD children, they're much worse. Now, I will say there are people and there are children that did very well during the pandemic. You know, it's not saying that this was every single child out there that experience this level of distress. And it's important for us to recognize what it is that led to that. What were the differences between those populations? It's okay. All right. So distressingly, and actually, so distressingly, what the 2020 mental health and American youth data has shown us is that while there's increases in every category of mental health measure, and we're talking about behavioral disturbances, ADHD, eating disorders, substance disorders, the percentages of those that did not receive services was also quite high. So for example, we know that in 2020, there was a 13.01% increase in adolescents aged 12 to 17 who suffered at least one episode of what we would diagnostically consider major depressive disorder. In 2021, that number increased further. Then we have 13.84% from 2020 increase in 2021. However, when we looked at those numbers, 59.6 did not receive any services whatsoever. That's quite distressing. And whether that's because the services weren't available or because they weren't even identified, is not quite known. Now, so despite the general overall increases in mental health concern, what we also know is not only were they not getting services, they weren't actually getting the supports in the areas they needed. So we see that in this 2020 survey, only 0.73% of adolescents who had a diagnosis that would have considered them for an IEP received an IEP. 0.73%. Now, I won't say that every diagnosis needs to have an IEP, but I'm sure that is way below the number of people that would have needed to have an IEP to be successful in school. So part of the lack of treatment comes, as you might guess, is legitimate lack of access. Here's some data that I pulled from the state. This is from 2015, which is the latest that I could find, which talks about mental health providers in my county in Arizona. Now, what do you see here? In certain counties, there's 1 to 3 to 0 psychiatrists available, family medicine physicians as well. And this is looking at numbers, providers per 10,000 children ages 0 to 17. We were looking at psychologists, the numbers, the licensed social workers, all people that would be identifying and providing services for our children. The numbers are pretty distressing. So they basically, frankly, don't meet the needs of our community. So best practices, let's talk a little bit about, because hopefully if I kind of haven't like depressed you fully, I want to talk about what we have an opportunity to do about this crisis and reflect on things that we're already doing well. And at the very basic level, what we have to do is we have to look at our institutions. We have to be innovative. We have to change more than at an individual level. And now I'm going to say something that you might be very surprised to hear a psychiatrist say. It is not all about the medications. It can't, in fact, I'm not even going to talk about medications today because it's not really what's going to fix this issue. It isn't an issue that we can fix overnight, and it's not going to be fixed with a single prescription. So ensuring that healthy children and families in our communities will it's going to take a societal effort, including policy, institution, individual changes, and how we view and prioritize them. Now, the first thing I'm going to urge people to do is to step back from the concept of diagnostic criteria when we look at individuals. We look at it from a biopsychosocial. We know that mental health is shaped by many factors, from our genes and brain chemistry to our relationships with our family and friends, our built environment, and larger societal forces and policies. For instance, we know that young people are bombarded messages in the media and social media that erode their sense of self-worth, telling them they're not good enough, smart enough, rich enough, popular enough. We know that there's little space in schools, they have stressors from schools to say that they need to do more to be more successful, to get into that right college, to have that career that they want. And we know that there's very little space for expected mistakes that we should be making in adolescence to learn. And that I know that all of us, and I know I made in adolescence, but was lucky enough to not have social media and have classroom everywhere. These kids don't have that opportunity, and it makes it very difficult for them to learn. And when we look at that, when we look at the person at the very basic level, from the individual to the family, to the community, to the environment, to the society, we are able to then form a picture of what we can do to intervene. So where do we start? At the very basic level, we need to move from deficit language to strength-based language in everything that we do when we work with adolescents. And by doing so, it gives us an opportunity to focus on coping, on resiliency, and building up. So what do I mean by that? I'm sure most of you have seen treatment plans. They talk about, what's the problem and what the role of the client is going to do, the patient's going to do. So the problem being, they need to stop talking back to the family. They need to stop skipping out on school. They need to, what are they going to do about that? Well, a lot of times the client doesn't actually have a say in what the treatment plan is going to be. It's just set for them. So that isn't helping anybody at all. So I always urge people to say, hey, let's focus on strength-based interventions. So let's talk to the patient and say, hey, what are you good at? What makes you a good student? What makes you a good friend? What makes you a good sibling? What is it that you like? And how do we incorporate and take that into how we plan and build a relationship with the patient in order to build them up? Because I'm sure that every single person in this room has remembered something that was said to them that was negative, that wasn't said in a constructive way. And you, 20 years later, can still remember those words, right? It's the same thing when somebody's done the opposite and told you something really good and said, hey, you're really good at that. How can I help you do that better? So that's the kind of thing that we should be working on. And I think it can be a simple intervention, even though it's a way of reprogramming our brain, because we weren't taught to do this. Or many of us who've been here longer than a few years, I think more recently it's better. So this is obviously not about adolescents, but I think at the also basic level, we have to start from the beginning. We have to provide practices that ensure that we are supporting our students from the very beginning and giving them the skills they need to build upon as they grow. So some good practices that I've seen and that I know are being implemented are how to teach boundaries, how to teach healthy relationships, how to teach problem solving and managing struggles in a healthy way. So two programs that I know are out there are Good Behavior Game, and I Can Problem Solve. And these books, you can buy them, especially the problem solve books, I can buy them on Amazon. And you can go through and they practice skills and the games you can play to help learn some of these skills. And they build them as they grow older. We need to be able to do this. There's also programs that, interventions that help behavioral management as a whole school or as a classroom. Because we do know that when children keep getting expelled or put in detention and being told that they're wrong and they're not part of their classroom, being told to leave, they build negative self-worth. They're not successful. It's not how we need to help. So if we can look at school-wide positive behavior intervention support, we know that it improves school student outcomes. It reduces exclusionary discipline. It improves teacher outcomes. It makes people generally happy as a whole. So this is the type of interventions we should be putting into our schools right now. So another practice that's out there that's readily available to everybody is mental health first aid. And many of us are trained in this. We use it with our adults. But this is from the National Council on Mental Wellbeing. But did you know you can actually make this or teach adolescents to do this? And this is a way of adolescents learning to identify mental health issues, being able to know the language to talk about it with people, and how to support people getting the help they need. Now, a big part of it are things that they can actually learn that are life skills, like how do I listen non-judgmentally? How do I actually be an active listener? How do I provide reassurance? How do I encourage people to get self-help? How do I support myself in doing that? Because we know that when people identify mental health in others, they know how to identify them themselves. So it helps them and it helps the community. And this is something that people can be trained to train others. And it's a great program. So I think it's a great way to implement in high schools to be able to have people support each other. Other aspects is prevention. So not only do we advocate for people recognizing and identifying issues, we want them to be able to say, hey, mental health is not an issue. I mean, it's not a bad thing. I mean, it's important for us to recognize what is good for you, what is not great for you, and to recognize where to intervene. So this is another program that's called a B4 Stage 4, which teaches the stages of mental health wellness and when to intervene, when you know that you need to be getting the help that you need and how to intervene for yourself and for others. Okay, so what can you do? And this is everything, right? What can you do? Represent people, talk about mental health, don't make it something that should be hidden. I come from a culture that does not talk about mental health. I mean, when I decided to be a psychiatrist, people were like, why? I mean, why would you want to do that? You know, that's not real medicine. And so, but I know that it's not. I can see how much it affected the intergenerational trauma, how it affected people not talking about these issues. So represent and advocate. Recognize that there's an issue, learn to identify it, teach other people to identify it. Empower students, empower the community to be able to support themselves, their families, their children. And then we gotta work on gaining access. So this is one part of this, is that we're teaching people, we're teaching the future to be able to provide these services. Support each other. Mental health is a very difficult field, and it takes a lot out of you. So be able to support each other and support everybody around you doing it. Teach and foster resiliency, innovate programs that can be built into your programs, into schools, into primary care. Address social determinants of health. We know that's a big one. Remember that when you're talking to adolescents, it's their experience. Your experience is not their experience. They live in an entirely different world than what we grew up in. And then correct and share. If you see something that's stigmatizing, say something. Bring it up. Say, you know what, I don't like that we use that word. You know, a patient Tuesday was telling me, like, I know that I was designated a frequent flyer in the hospitals. I know that they wrote that in my notes. It made me feel like every time I went there that I didn't need help, that I was just seeking attention. And I don't like it, and I still remember it. Those words, they're powerful. You know, 7 years later, she's remembering that. So we need to correct when we hear that. And then lastly, advocate, especially in schools. I mean, starting school at 7:30 in the morning and having classes till whatever time, and then extracurriculars, and kids don't get home till 7 and they have 5 hours of work. How is that helping our students succeed in life? I mean, that's just teaching us bad habits that I know I still have. So it's not necessarily helping. So when you see something like this that isn't working, that is working against us, we need to advocate for making changes. So lastly, you know, as Dr. Murphy said in the report, in the 2021 report, only we can demand change. Well, only we can demand change will we be able to protect, strengthen, and support health and safety of our children, adolescents, and young adults, and ensure everyone has a platform to thrive. And, you know, there's a couple of resources that I really like that I hope that people can look at. Mental Health America, National Council on Mental Wellbeing, that has a lot of programs. They talk a lot about research that has been done, programs and what their efficacy was, empirical data, stuff like that. And lastly, I just want to thank you guys for being here, and also just tell you guys to also take care of yourselves while you're taking care of others, because you are very important and we need you here around. So thank you so much.
Thank you for your questions. If you have questions, remember we're asking questions through the app, so just put in your question in there. So far, the only question is we're requesting a copy of the slides, and we'll be downloading those on the webpage so that you can download them.
Yes, on Dr. Arredondo's webpage, we'll have the slides uploaded later today.
Thank you. So yeah, so they'll be on the webpage that you can download those slides.
Okay. Wow, it was so amazing that you guys have like awestruck. Well, I'll give you back your time, I guess, and thank you guys for being here.